All right, so hi everybody. Thank you so much for joining me, especially in the bitter, bitter cold. We appreciate everybody being here. So my name is Destiny Campanella. I'm the program director for Savage Sisters. Just a little bit about myself. I have a bachelor degree in social work. I've been doing harm reduction for over 10 years, but mostly in the Philadelphia area, so I'm really new to this area. I'm really excited to meet you all and connect with all of you. I'm the former harm reduction coordinator for the Philadelphia Department of Public Health, where I implemented their first formal fentanyl test strip training, and I spearheaded the city's fentanyl test strip campaign. Previously, I was another harm reduction director for another organization where I spearheaded and led a statewide harm reduction program in the surrounding counties, as well as virtual oversight in Pittsburgh. I've been on the board of directors for Savage Sisters for over 4 years, and I recently have been gradually stepping down over the last several months, and I've just started with them full time. So it's really only like 2 weeks that I've started as a full-time employee, but I'm very excited. I'm loving it. I feel like it's exactly what I'm meant to be doing. So I'm gonna go over a little bit about what Savage Sister is. Is anybody not familiar with Savage Sisters? Oh, okay, so pretty much all of you. So I'm gonna go over what our program, who we are, our mission, our programs. Then I'm gonna go over some really sad death data. So I'm going to go over what this public health crisis is looking like. I'm going to go over some current drug trends. I'm going to talk more about the trainings that we offer. And then we're going to slide into our panel discussion. Sound good? And then we'll get into our Q&A. Oh, I have a clicker. Oh, an agenda. Yeah, so this is what, sorry, it's been a long day. So this is what our agenda's looking like. Okay, so I know all of you pretty much are familiar with Savage Sisters, as you just said, and you know that several of our members and our executive director and founder has grew up in this community, right, Charlie? Am I getting that right? Okay, I just wanted to make sure. How Savage Sisters originally started was that our founder and executive director, Sarah Laurel, is a person in long-term recovery, and she was really sick and tired of going to these recovery houses that really should not have been recovery houses. She was really just wanting a safe place for herself and her friends to recover. So originally, Savage Sisters just started out as a recovery home, and since we've expanded. So now we have a total of 9 recovery houses in Philadelphia and Delaware County. We are a structured trauma-informed recovery house program. We do embrace multiple pathways to recovery. So if a person does want to do traditional NA or AA or traditional 12 steps, they are more than welcome to do so. However, if that's not the path that person chooses, that's okay too. So if a person needs medication, they're welcome to be on any type of medication assistance recovery. If they want to do alternatives, if they want to do smart recovery meetings or anything that's just not your traditional 12 steps, they can. We offer trauma-informed therapy. We do kickboxing. We do yoga, meditation. Am I missing anything else? Good.
We host smart recovery meetings weekly.
Smart recovery meetings weekly? Okay. A huge part of Savage Sisters is our training and education. If anybody's interested in any of these trainings, you can feel free to connect with us. So we do overdose prevention and reversal trainings on a national level. This is a very, very extensive training that talks. So a lot of the information I'm going to be presenting on. You can get all of this information into the overdose prevention and reversal training. In addition to how to recognize and respond to an overdose, I always tell people, even if you took an overdose reversal training before, always make sure that you're taking updated trainings because our drug supply is always changing. So it's very, very important that we're getting up-to-date information because overdoses and responding to overdoses look different. So we do offer that training. It's typically an hour and a half. And like I said, we do that on a national level. We offer basic harm reduction training. So what this training is, it talks about what harm reduction is. We talk about the 8 core principles that we're going to talk about in just a little bit. It talks about a lot of drug war history, the evolution of the harm reduction movement, in addition to safer use supplies and why we use them. We offer trainings on drug testing. When I say drug testing, I mean how to use like fentanyl and xylazine testing strips. And we offer a very in-depth xylazine training, and we offer that Charlie does a really, what is it, basic wound care training? Am I getting that right? And then we do like a harm reduction approach to outreach. So if you have or you know of an organization that is engaged in street-based or community outreach, we can definitely provide a training on how to engage with an unhoused population or maybe how to enter an encampment. We're happy to provide that training as well. Well, this is such a good picture of Sarah. So outreach, this is my absolute favorite part of my job. So Savage Sisters does do outreach. I'm sure a lot of you have seen and heard of the media. Savage Sisters used to have a storefront located in Kensington. Again, if we all heard that in the media, so you know the mayor administration kind of forced us to shut down our storefront in Kensington. However, we are now operating fully mobile. We're going to go wherever our friends go. We have a Sprinter van and we have an RV van where we're able to offer shower services for individuals, linkage to care if they want to. We never force people into treatment, but if they want to, we're happy to link them to any higher level of care that they're interested in. Charlie does wound care. We offer other supplies, naloxone. We offer, today it's very cold, so we were out offering cold weather supplies. We're doing 3 a week in Chester, Upper Darby, SEPTA. We do Old City, South Philly twice a week. We do Kensington. And then we have our very large monthly outreach. It is the 3rd Saturday of every month, and that is in Kensington. So if anybody's ever interested in donating, volunteering, we are always looking for volunteers. All right, can somebody tell me what harm reduction is? There's no wrong answers, just call it out. No? Has anybody ever heard that word?
Providing clean needles.
There you go, okay. See, there's no wrong answers. Anybody else?
Correct me if I'm wrong, but the whole idea behind the harm reduction is to reduce the number of deaths related to overdose and helping them find safe ways into treatment.
Yeah, there you go. See, this is just a Wikipedia copy definition. I know Charlie was just saying at his training that he doesn't like the word dumb it down. What did you say? More digestible. I really like that. So this is not really digestible because this is just copy and pasted off the internet. There's no wrong answer to what harm reduction is. Both of your answers were right. To me, in my own words, harm reduction is just respecting somebody's autonomy. Most people, when it is affiliated with drug use, I don't want everybody to always affiliate harm reduction with drug use or safer use practices. I always use the alcohol example because that is the legal substance, right? That is more socially acceptable. I remember being in my early 20s, and my mother used to tell me, hey, make sure you don't drink on an empty stomach, Make sure that you're not mixing your alcohol beverages. Never leave your drink unattended. If you're going to the restroom and you're out, make sure you always bring one of your girlfriends with you, so use the buddy system. So those are just some examples of practicing harm reduction when you are engaging in, safer use practices. Alcohol is just more, like I said, more socially acceptable. My mom never told me, go get drunk, it's gonna be awesome. Yeah, but she realized, okay, like you're gonna be doing this. She just wanted to make sure that I was being safe. So here we have the 8 pillars of harm reduction. You can find these right on the National Harm Reduction Coalition website. They have like a really cool, colorful PDF form. You can feel free to print them out. Like I said, so there's no universal definition of harm reduction, but most harm reductionists, we go by these 8 core principles or 8 pillars. And in Charlie's words, here they are, more digestible. So people do drugs, always have, always will. Let's make it safer. So people have been using drugs since the beginning of time. The whole just say no approach, that has never worked, and it's still not going to work. We absolutely can make it safer. I think we can all at least agree that we just don't want our friends to die, or we don't want our loved ones to die. Drug use is not a black and white issue. You actually can use safely. So drug use is not black and white, meaning that drug use happens on a continuum. There is a huge difference between drug use, and substance use disorder. Two entirely different things. But you don't have to be a problematic or chaotic drug user to be at risk for an overdose. So it's still important that everybody is being safe, and everybody should be carrying Narcan. Abstinence is an outdated, archaic, unrealistic expectation. So abstinence might work for some people, but it doesn't always work for everybody. So if a person, to me, I am a person that embraces multiple pathways to recovery. That looks different for every person. If somebody has stopped using one substance, but they're still using another, like if a person's like, I stopped injecting fentanyl 10 times a day, but I'm smoking meth. Okay, that's a form of recovery. Like, good for you. It's any positive change. So it's really important that we understand that abstinence is not for everybody. So be nice, don't judge, don't force. I have a shirt that says be nice to drug users. So I think we should just be nice to humans in general. So you will see PWUD. So that means people who use drugs. Like I said, drug use happens on a continuum. I'm not a provider. I'm not out here diagnosing people. So that's why we say people who use drugs. We don't always label people with substance use disorder, or SUD for short. We certainly don't use the term addict or addiction. We always use person first language. So that's what PWUD means, people who use drugs. So number 6 and number 5 is going to tie in together. So people who use drugs are the experts, and they're uniquely qualified to serve. So when we're implementing policies and change, it's really, really important that we're including people who use drugs right at the table. They are the experts. I cannot get in front of rooms of all you wonderful people if I'm not out there doing the work and I'm not out there talking to people who use drugs, because they are the ones being directly impacted. They know what works, and they know what doesn't work. So it's very important that we're including people who use drugs, and we're bringing them to the table, especially when we're implementing policies. So trauma is the gateway drug. Has anybody ever heard marijuana is the gateway drug? Okay, right. It's, super outdated. I always say trauma is the gateway drug. That's also a quote by Dr. Gabor Mate, one of my favorite authors. Please check him out. He's amazing. Be real and honest based on history and evidence. So a lot of times, like I said, I've been doing this work for a decade. And when I get in these rooms, sometimes people, although some of them might mean well, they might say, okay, you and I just have a different perspective, or we might just have a different way of looking at things, when not really. Harm reduction and what I'm talking about has been backed up by a plethora of science and data for decades upon decades, like well before my time. So we're not talking about whether Santa Claus is real or the Tooth Fairy is real. What I'm talking about when I'm talking about harm reduction, it all has been backed up by science and evidence. Would I surprise anybody if I said that we have not seen heroin since 2016, so almost a decade? Okay, so you all know. All right. So most of you kind of already know that. So I'm going to just talk about a couple of illicit opioids today, and I'm sure do you know what I mean when I say illicit opioids, right? So there's a difference between pharmaceutical opioids and then there's illicit opioids. You see, with heroin, you kind of have to grow it, you have to extract it, you have to transport it into the country. But because fentanyl is man-made, so it's kind of made and manufactured similarly to meth, it's significantly easier and much cheaper to make and manufactured versus heroin. So, like I said, we have not seen heroin since probably late 2016. So the year 2017, that is the year that fentanyl completely dominated Philadelphia and then made its way to the surrounding counties and quickly dominated throughout the state of Pennsylvania. That is also the year that we saw a peak in overdose deaths. That year nationally, we lost over 72,000 people due to a fatal overdose. I also tell people to be really wary about those numbers. This is a two-layer issue, stigma being one of them. A lot of people don't want to talk about how their loved one died. Sometimes you hear about a person in their early 20s and their death has been ruled as a cardiac arrest. But like I said, we have not seen heroin since that point in time. We're also seeing a number of counterfeit pills on our streets. This is nothing new. This is something that's been happening for quite a few years. However, this is something that's been significantly increasing. Not only has this been significantly increasing, but these pills are beginning to look more and more realistic. Usually, you'd be able to tell the difference because if I held a fentanyl press pill in my hand with a real opiate in my hand, something about the print would look a little off. It usually would have like a more of like a chalkier like texture and feel to it. However, these pills are beginning to look more and more realistic. When I was working at one of my previous jobs for the city, I was able to get a counterfeit oxycodone pill from where I live in South Philly. That pill tested positive for 4 different fentanyl analogs, gabapentin, and Tylenol. No other opiate was detected in that. And Savage Sisters, we do offer more extensive training to kind of get into this if we want more information. Oh, I do kind of want to be mindful of time too. So why heroin or fentanyl and now xylazine? So this slide here, what I'm about to say, just makes economic sense. So people who have misused opioid pain relievers are 19 times more likely than others to start using, which historically was heroin. So we can teach an entire college course on this, and there are college courses on this, so not every person who puts an opiate in their body will and does form a dependency. It really does depend on a number of different issues. So I say that because how many of you ever had a surgery before? Okay, have you ever been given like pain pills to treat your pain for the surgery? Did all of you form a dependency? Okay, so not all of you. So I just say that because not every person who takes a prescription opiate will form a dependency. It depends on a number of different issues. But 19 times, why am I trying to say that? Most people who do end up forming dependency have started out with using some form of prescription pill. Now, whether that was prescribed to you or you went and bought that off the streets, that is most people. So if you're paying, I think it's, what is it, Charlie, help me out, $45 between $60 per pill if we're getting an opiate? Yeah, for real one. So, and if we're taking like how many, like 8 to 10 pills a day, what's that, do the math for me? Like $600 a day?
10 pills a day, full price, $600, they have it.
Mm-hmm. I majored in social work because I can't do math. Thank you, Charlie. Okay, so I don't know anybody that can afford that. And, you know, we don't really talk about people getting high anymore. People are just trying to get well. So for those individuals who do end up forming a dependency, meaning they are dependent upon that opiate, they just don't want to go into severe withdrawal symptoms. Some of those withdrawal symptoms include severe muscle ache, severe muscle cramp, nausea, cold sweat, diarrhea. So what ends up happening as that person's tolerance increases as the days go on, they can't afford it anymore, right? And like I said, people are just trying to get through their day without feeling very, very sick. So they turn to heroin, which is cheaper and stronger. Historically, heroin used to be $10 a bag, where fentanyl was $5 a bag. So like I said in the previous slide, fentanyl is cheaper and easier to make and manufacture versus heroin. What happened was the media and our public health officials have really started to pay attention to fentanyl within the last couple of years. So they really started to crack down on it, hyper-focus on it. It got a lot of media attention. So then xylazine. Drug dealers have one job. Their job is to sell drugs. You are never going to eliminate drug use. You are never going to eliminate drug sales. Once a dealer gets their supply confiscated, they will always replace it. And what ends up happening is they replace it with something that's more potent and more harmful and more deadly. And that's always going to happen. So fentanyl is 30 to 50 times more potent than heroin, and like I said, it's cheaper to make. So another important fact to understand about fentanyl, it has a much shorter half-life than heroin, meaning people go into withdrawal much sooner than they would, sometimes an hour after 3 hours. There's also over 150 fentanyl analogs. No, I don't know all of them. I just know there's over 150. So we're going to go into drug use, mental health, and substance use disorder. So like I said, drug use happens on a continuum. People use drugs for a number of different reasons. So whether that's experimental use, recreational use, situational, binge use, misuse, or severely and chemically dependent. Like I said, there's a big difference between drug use and substance use disorder. So substance use disorder and mental health go hand in hand, right? They're pretty much the same thing. So Some people actually may use substances to cope. I've engaged with a number of different people that are like, if I did not use drugs, I would have killed myself, because like they have experienced such a horrific trauma in their life or years of traumatic events that they said, I needed this substance to cope. I don't know if any of you are a person in recovery, or even if you just maybe you're having a really stressful day, you're going through a really hard time, maybe you're grieving or whatever may be going on, and you go home and you have a glass of wine, right? It's pretty much the same thing. Or you take a Xanax, or you take a Klonopin. It's pretty much the same thing. Some people just need substances to cope with an underlying mental health condition. Circumstance. I really want to. I don't have too much time to go in on here, but I really do encourage you to look up. There are several studies that suggest people use drugs as a result of being unhoused. A lot of times when I have conversations with people who are, I call NIMBYs, they're not in my backyard, when they say that, people they end up homeless because they use drugs in their home, when actually there is quite a few studies that suggest that people use substances as a result of being unhoused. Think about how cold it is outside right now. I don't know about you. I was not I don't come from money. Especially I'm a very young single mom, so I think about how privileged I am to have my parents. But if I didn't, I don't know what my situation would be like. Hey, could you imagine if you were unhoused and it was freezing? You probably would be using a substance to cope with living outside. This is, again, I'm such a fangirl of Dr. Gabe Ramonte. So one of my favorite quotes is, he says, ask not why the addiction, but why the pain. So substance use disorder is considered both a complex brain disorder and a mental health condition. Like I said, mental health and substance use disorder absolutely do go hand in hand. It is a mental health condition. It is in the, everybody familiar with the DSM-5 here? Okay, so all of you, great. So it is in the DSM-5. And 1 in 5 Americans experience a mental health illness each year. So now I'm briefly going to go over some overdose data, and then we're going to get into our panel. So here we have our national drug-involved overdose deaths. So a little bit outdated, but still kind of makes the point I want to make. So you could see these maps are from 1999 all the way from 2021 here. So people talk about this crisis sometimes if it just came out of nowhere, when that's just not the case. This is a crisis that's been around for decades upon decades. So you could see, like I said earlier at the beginning of the presentation, 2017, that is the year we saw a peak on a national level. That is the year fentanyl completely dominated our drug supply, where we lost 72,000 people due to a fatal overdose. And then you could see we had a slight little decrease here. We're not celebrating. It was like this. You see how slight that decrease was. We're not really celebrating. And for 2021, we lost over 100,000 people due to a fatal overdose nationally. So this is the largest public health crisis in our entire history. We are losing more people than the height of the AIDS epidemic. I always tell people, be really wary about death data. First of all, it takes almost 2 years for death data to be finalized. This is not including individuals who die from drug-related harm, like endocarditis, cellulitis, or maybe other infections that may have been caused by something like injection drug use. Or I know an individual who, either overdosed behind the vehicle of their car or nodded out, crashed and died. So be very mindful. These numbers are probably much higher than what our data actually tells us. And this is all public information. You could feel free, I'm not an epidemiologist, but you could feel free to look further in this information. It is all public information right at the Pennsylvania Department of Public Health. So Philadelphia, we are the highest rate in overdose deaths than any other major city. Chicago is second, and we are 3 times higher than Chicago. So Philadelphia for last year, or this is 2022, for 1,413 people, and for Allegheny County, it's 700. And you could see, here's numbers by county here. Philadelphia alone loses approximately 3 to 4 people a day due to a fatal overdose. The state of Pennsylvania loses 14 people a day due to a fatal overdose. And again, this is more death data. So it's important to remember this is death data. So this is whatever the person happened to consume during the time of death. You could see that there's actually been, from looking at this map, you could see that orange line there that is opioids. There's actually been a decrease to like pharmaceutical opioids. People are not essentially dying from pharmaceuticals, they are dying from illicit fentanyl. And you could see there's been a significant increase to fentanyl-related deaths, as well as cocaine and methamphetamines, as well as xylazine, which we're going to be talking about in just a little bit. Again, so it's important that we don't call this an opioid epidemic, because that's not what it is. It's really inappropriate for us to call an opioid epidemic at this point in time. Polysubstance use is very common amongst people who use drugs. Whether they use those drugs at the same time or whether different times, polysubstance use is very common. I also wanted to make a point here before we move on that, again, this is whatever the person happened to consume during the time of death. It is possible that the decedent could have had all of these substances in their system during the time of death. So if somebody, thinks, okay, there could be, fentanyl laced with the meth, we don't know. Because when the person passed away, they could have had all of these substances in their system at the time of death. We don't have any way of knowing whether that fentanyl use was intentional or unintentional. So now I'm briefly, and I know I do want to get to our panel, I apologize. I do want to talk about current drug trends, and like I said, we offer more extensive training so we can talk more, we go into more detail about all of this. So everybody here, I'm sure, is familiar with xylazine, right? It's gotten a lot of media attention, so a little bit. So you might have heard people refer to it as trank. I remember when it first hit the streets in Philly, people called it trank dope. The media calls it a zombie drug, but think about what we do to zombies in movies, right? We shoot them and we kill them. Very terrible, stigmatizing language. I always tell people, our friends on the street, they are not zombies, they are victims of the criminal drug market. Because the criminal drug market works, it's kind of you get what you get, and you don't get upset. Nobody really asks for this. So what it is, it's a veterinary drug. It's used as a sedative. It causes, well, first of all, I always say that obviously animal trank is going to have a different effect on a human skin versus the animal skin. If you have any questions for Charlie, he does wound care, so it's been affiliated with some really gnarly wounds. You can feel free to ask him questions. It's commonly used to adulterate heroin, fentanyl, and cocaine. Remember when I talked about how heroin has a shorter half-life than fentanyl? We believe that that's one of the reasons why xylazine has started to make its way into something like fentanyl, because it extends the euphoria. It gives the fentanyl the longer legs. It causes individuals significant respiratory distress. So when you're in certain parts of the area where xylazine is very prevalent, like Philadelphia, you'll see people that look very, very heavily sedated. They're very knotted out, hunched over. That is from all the xylazine that's being cut into our dope supply. It was found in Philadelphia as early as 2006, so this is nothing that's new, but it completely dominated our drug supply from probably 2020, and now it has been found in 99% of dope tested in Philadelphia. So now, yes. No, you're fine. No, it does not. Thank you. Yeah. Thank you. No, it is not an opiate. So naloxone is not going to work on xylazine. Savage Sisters does offer a really informative training on how you can best respond to an overdose with xylazine in the supply. And then there's medetomidine. So, like I said, drug dealers have one job. Their job is to sell drugs. So what started happening was the media and our, public health officials have really started cracking down on xylazine. They scheduled xylazine, and like I said, when the supply gets taken away, a new and more deadly one is going to take his place. So now we have medetomidine. Medetomidine is very chemically similar to xylazine. So basically, it is also a sedative. Both of them affect a person's brain receptors, because like I said, it's not an opiate. It's going to affect the brain receptors, similar to the blood pressure medication clotidine. Pretty much has the same effect. I would say, Charlie, please correct me if I'm wrong, is the only difference we see, I feel like individuals have more psychosis as a result of consuming medetomidine. Would you say that?
Yeah, so we've seen an increase in the number of people having psychotic episodes. I've seen an increase in like seizure-like activity, especially when people are going through withdrawal, like when they haven't dosed in a while once they become dependent on the medetomidine. But other than that, the effects are very similar to xylazine. There's the very heavy sedation, bradycardia. Yeah.
Thank you. We first detected it in Philadelphia as early as April of 2024, and we are seeing it in more and more samples, which means be prepared. It's going to come up this way, just like everything starts in Philly, and it's going to make its way up here. So it's something just to, be on the lookout for. All right. So I do want to get to our panel, and I want to give time for questions. So if you need further information, if you want to schedule one of our trainings, like I said, we do offer very, very informative, intensive trainings, especially on overdose reversal. Please feel free to email info@savagesisters.org. We have a very large social media presence. If you use Instagram, Facebook, TikTok, Linktree, give us a follow. Sorry to kind of rush to the end. I wanted to get to the panel. Should I leave this? Yeah, I'm gonna leave that up there. All right, so can you take about 3 to 5 minutes just to talk about yourselves and what you do, and then we're gonna open it up to the audience? Okay.
Thank you, Destiny. Hi, everyone. My name's Charlie Nolan. I am the community healthcare specialist with Savage Sisters. I was hired on to do wound care during our street outreach initiatives. But with the closing of our drop-in center, my duties have changed a little bit. I do many of our education pieces. I came from a training at St. Joe's to be here tonight. So all of the trainings that Destiny listed, it'll either be me, her, or another team member presenting them. I spent a lot of time in the field doing street outreach, engaging with people who use drugs. I'm actually an alumni of the Savage Sisters Recovery Housing Initiative. My family lives in Radnor. My siblings went to Radnor elementary, middle, high school. So I'm really happy that I get to be here with members of the community where my family still lives. I appreciate you all having me out. Any questions you have about our outreach initiatives, about wound care, about xylazine, about people who use drugs, I am 100% happy to answer. Did I cover it all?
Yeah, just 3 to 5 minutes. Thank you.
All right, cool. Thank you all for having me out here tonight.
Thank you.
Good evening, everybody. I'm Steve Forzato. I'm with St. Joseph's University. I direct the St. Joseph's University's Center for Addiction and Recovery Education, or CARE. It was started about 5 years ago. Alumni from the class of 1985 included an individual that, though he's extremely successful in business, both he and his wife, he did suffer from alcohol use disorder. Could not stop. He just couldn't stop. And then finally, he was picked up by the local police lieutenant during a DUI, and that's what woke him to the idea, I have to find help. And so he went to a really good treatment center and got some help, and he's about 20 years in recovery now. He and his wife have no children. They decided they're going to give every dime of their money, their sort of inheritance, to programs that address substance use disorder. So he started CARE at St. Joe's. And Lieutenant, they hired me, a 33-year veteran of law enforcement. So I spent 31 years in the Montgomery County District Attorney's Office, in the County Detective Bureau, went through all the units, homicide, crime scene, major crimes. But my love was narcotics work. So I'm sorry, but I love working undercover. And mostly because the people that I encountered, not as Steve Forzato, but as Anthony Randazzo. That was my undercover name. I can finally come out and say that. We're such beautiful people. They may have been using substances, and certainly were in my presence, but I really enjoyed hanging out with people. And of course, our targets were not users. They were the suppliers, the dealers. And so I got my street PhD, like the lieutenant did, on the street. I don't have a doctorate, but kind of have a street doctorate. And I was just so happy to, learn towards the end of my career that treatment for substance use disorder, including recovery support, it actually works. It actually works. People do get well. In fact, I was told by someone in recovery, people get better than well. So somebody who's not ever had a substance use addiction issue, you know, we're all whatever we are. People that get well, like a lot of our friends here tonight, all of the people that I love and adore at Savage Sisters that are in recovery, like they're doing exceptional work. And sometimes I think far beyond what those of us that aren't sort of in need of recovery, we achieve some, but they achieve greatness. So with the 3 to 5 minutes, I am happy to answer your questions. If you feel as though law enforcement could take a different perspective on things, ask me those questions, please. We've been educating police, first responders for about 5 years now. 10,000 people we've educated on the issue, and we don't point fingers and say you're doing everything wrong. We simply reach out our hand and say, hey, I appreciate the courage that you have in doing the job that you're doing, but let's talk about substance use disorder, and let's figure out, are there other ways you can be helpful as well? And so it takes courage to connect people to treatment, just like it takes courage to go out there undercover and buy dope. So anyway.
Thank you so much. Questions?
Come on, hit us with hard
Yeah,
questions.
come on. Your
Yeah.
question?
Not too hard.
So, unfortunately, I'm very familiar with substance abuse, and I know with opiates and fentanyl, the withdrawal protocol is going to be vastly different than with xylazine or anything else. Obviously, you can't do a methadone taper on xylazine. Are you guys using ketamine and in order to deal with the withdrawal? And how is the education for recovery programs handling the change in drug, if that makes sense?
It makes perfect sense. That is
Great question.
a fantastic question. So I want to be really clear. We are not like a medical provider. We don't give anyone medications. We're not licensed or authorized to do that. Like, we can't even give people antibiotics. We do advocate every chance we get, every time we're in a room with medical professionals, with hospitals, with the people that are licensed to make those calls, that we need a widely accepted update to withdrawal management protocols. Because like you said, the medications like buprenorphine or Suboxone, methadone, that we use historically to treat opioid use disorder, opioid withdrawal, they don't touch xylazine withdrawal. Xylazine's not an opioid. It has an entirely separate withdrawal process than, let's say, fentanyl withdrawal. So most individuals who are using dope from the street, they're not withdrawing from just fentanyl. They're going through 2 withdrawals at once, which is a really big barrier to both getting people into medical care and getting people into like substance use treatment. It's a huge barrier to overcome. Generally, when we're working with people and they say like, I want linkage to care, I want treatment, like the window for taking action and getting that person into treatment is this big, and any barrier will shut it almost immediately in most cases. Anecdotally, like I said, I do wound care, and I learned wound care from my nurses. I'm not a medical professional. But what I've heard from the individuals that I work with medication-wise that work best are going to be ketamine, low doses of short-acting opioids, things like Dilaudid, and if that's not available, a benzo like a Xanax or a Klonopin, in addition to like blood pressure medication, because blood pressure issues do come up frequently in xylazine withdrawal because it's so chemically similar to blood pressure medications. Now, obviously, ketamine, low doses of opioids, and benzos are all respiratory suppressants, so these would have to be taken under the watchful eye of a doctor, hopefully in a hospital. And there are some hospitals that are like using such combinations of medication, but there's no like widespread accepted protocol. We need studies to come out. We need funding for studies to come out. We need human studies because we're working off rat studies right now. So unfortunately, we're like a pretty we're pretty far down the line from having what we need in that withdrawal management protocol. Did I answer your question? I know I get rambly.
Are the recovery programs at least open to the information that you're giving them?
They're open to receiving it. Beyond that, I don't know what they do with it internally. What I will say is we've had, just as harm reductionists as a whole in southeastern Pennsylvania, have had a better time advocating directly to hospitals versus substance use treatment centers. At least from what I can tell, like hospitals are a little bit more willing to, for lack of a better term, experiment as to what will keep a person comfortable more so than treatment centers.
Who else has a question? You.
Regarding the xylazine withdrawal, well, first of all, it's used to cut a lot of agents on the street, if I understand correctly, and individuals become stuporous, right? You know, zombie or whatever. But in the withdrawal situation, is there like an emergence delirium? I mean, what exactly is the presentation for a xylazine withdrawal?
That's a good question. Typically, the biggest differences we see between xylazine withdrawal and an opioid withdrawal are going to be more severe agitation, in a more extended period of restlessness because the body's just so used to being heavily sedated to like an extreme point for so long. I've spoken with people that are like, yeah, I haven't slept in 10 days. Delirium, infrequently, but occasionally going into psychosis, which could be from that lack of sleep and that lack of rest. But really, what I see the most is, like, when people are withdrawn from opioids, they are typically pretty agitated. They don't feel well, but to a much more severe degree when it comes to the xylazine. And then medically, we have the issues of a generally elevated heart rate and generally like extremely elevated blood pressure.
Right, you get a rebound hypertension,
Yep.
and you become very, hyperdynamic, with blood pressure and heart rate. Something perked my interest, the metomidine, the veterinary medicine for sedation. I saw 40 milligrams per ml. I'm an anesthesiologist. I use a drug called Precedex or dexmetomidine, and we're talking microgram doses, not milligram doses. 1,000 micrograms is 1 milligram. Yeah. We use Precedex or dexmetomidine for agitation, or people who are known to be delirious and very agitated coming out of anesthetic. And it works quite well. And I was wondering, is there any research that you're aware of? Not that you're using it, but any research or work done on that use in addition to ketamine and other things?
So there, I believe, is one study. So I have a list of like medications that have are not approved but have been shown to be helpful through xylazine withdrawal. It is on the list with ketamine and like gabapentin and low doses of opioids. I just personally haven't spoken with anyone who either has been used on or knows that it's been like used as part of their medication protocol while in the hospital. So it is something that people, I don't want to say smarter than me, but like more credentialed than me and can prescribe things. It's on their radar. I just don't know a ton about it personally. Yeah.
I was wondering if I had a follow-up question about the agitation. Would exercise be an option for someone who's agitated? Just like for anyone who's agitated for any reason, activity is always a good expression of that kind of agitation. Are they able or willing, or is it they're just not interested in an exercise activity at that moment? Are they too aggravated?
So I'm going to speak from my lived experience here. I spent a long time chaotically using drugs. It's going to be really person dependent, but when you're talking about such severe withdrawal and like a constant battle not to go to the bathroom on yourself and not to vomit on yourself. It's really hard to do much more than just like a walk. In theory, yeah, but yeah, it's pretty. Yeah, I don't know. From my experience, I wouldn't want to do it while going through withdrawal. I can't speak for everyone, but I see like your path of thought that took you there for sure.
You're excited about something, or you're got your cortisol rush to be in withdrawal.
Yeah.
That running or something would help dissipate that.
What I will say, and Steve just brought up a good point to me, is we have seen good success with like the exercises that we offer through our housing, like the kickboxing, the yoga. Like generally, the people that are getting like really involved in those and going every time are they're residents that are doing pretty well, like maintaining a job and like maintaining relationships with friends, families, and loved ones, and being like kind of cornerstones of their house.
So an early recovery, long-term recovery, for some, perhaps many, exercise is a really important part, perhaps new part of their lives that's very helpful, so.
Mind, body, and soul.
I just have a question. So Narcan was good for the heroin overdoses and the opioids. What is the on-the-street treatment for these newer drugs? Is there something?
Not chemically. So, to be really clear, the majority of the dope in our area is a combination of fentanyl and either xylazine or xylazine and medetomidine. So we're always still giving Narcan to take the fentanyl out of the equation. Because when you have two respiratory depressants, it's like a multiplying effect on slowing down breathing. So we're always still Narcaning. We get the fentanyl out of the equation, and then we're just left with that respiratory depression from the xylazine. We don't have something we can spray up their nose or inject them with on the street to reverse that. So it's made like rescue breathing, supplemental oxygen, really, really important. Our team, like when we're doing our street outreaches, we typically either have an oxygen tank with us with a mask or something called an ambu bag. You put the mask over their face and like squeeze the ball thing. Just because we've had to do rescue, like Destiny and I together have had to do rescue breathing on a person for 20 plus minutes. It's exhausting. So we started carrying other tools for that, but all we've got when it comes to tranq is that oxygen. And another important point too is if you don't have Narcan with you and someone's overdosing, call 911 and just give them like rescue breathe, mouth to mouth. Just and you can buy them enough time for that ambulance to show up, even if you don't have Narcan.
So Lieutenant, you had brought up this for your police department. So I'm sure your officers carry Narcan and likely use Narcan, correct? Yeah. So even though we have this substance, xylazine, out there, and this other, non-opioid substance that's out there, it's still appropriate for your officers to administer Narcan, if the signs of an overdose, an opioid overdose, are there.
We actually train that reason to believe that there's narcotics on board and
Yeah.
are exhibiting any signs
Yep.
of an opioid impairment, we're going to give the Narcan. A, because it works, and those of you who have seen it,
Yes.
it works incredibly well. B, if it is one of these other drugs, or God forbid some other undiagnosed medical condition, to my knowledge, it's not going to hurt them. It's not going to have any negative effects on them other than maybe giving them an upset stomach.
Right.
So our training is give it when in doubt, give it.
Yeah, and yes, I agree with that, because it could be xylazine is one of the main causes of the breathing slowing and stopping. But if there's any fentanyl in that substance, that Narcan will at least assist the patient with that. And then, because of this new wave of the overdoses with xylazine, officers now have to think about that second step of providing rescue breathing. Because when you do a Narcan rescue, right, it's like you're witnessing a miracle. It's just unreal to see this. And it's so exciting, particularly as a police officer, it's easier than CPR, right? To just spray,
Does all the work by itself.
does all the work by itself. But then with this new substance that's out there, now you have to start thinking that next step of rescue breathing. So like officers often have the medical supplies necessary to do the rescue breathing without, mouth to mouth. And there's one-way valves and there's rescue masks. And so, but we just have to be more prepared, all of us really, but including law enforcement to provide the rescue breaths.
Charlie, I was just wondering, can you talk a little bit about the compassion comeback?
Yeah, for sure. This kind of brings up, I just got lost in thought. So I have been Narcaned quite a few times, and it just occurred to me that the first time I was ever a recipient of Narcan was thanks to the Radnor Police Department. Was it you? Oh, wow. Insane. Thanks. Appreciate you.
Charlie, I'm glad you said something, because I was always proud of being there for you that day, but seeing you now, I would never even have recognized you. Never what you told me you would be sitting there today doing what you're doing. I swear to God, I'd have told you you're a liar. There's no way. I thought you were destined for dark places, and I couldn't be happier for you, and I couldn't be, if I may say, I couldn't be more proud of you.
I appreciate that. Thank you. That's crazy. Yeah. I'm not crying, you're crying. But something that really stuck with me that day was I thought I went deaf, which has happened other times I've been a recipient of Narcan. You never know when you're coming back, because it's a period of like unconsciousness. I couldn't hear right. I thought I was brain damaged. And through further research and like working in this field for the last few years and volunteering in this field since 2016, I've learned that that's actually a symptom itself of high-dose naloxone. And what we've discovered these last couple of years through being on the street, through working with other organizations, is with today's current drug supply, we didn't have xylazine back then. I just took a buttload of fentanyl, and I didn't even know it was fentanyl at the time. But with today's drug supply, it's such a small amount of fentanyl in our drugs, and it's majority xylazine. And the trend has been happening this way for a few years, where the ratio has become more and more skewed. People come out of overdoses very slowly now, to the point where if you don't have a monitor on their oxygen, if you don't have a pulse oximeter on their finger, you might not even know that they're out of danger at this point, because they're so heavily sedated from the xylazine. So what our team has started doing is, because it's such a small amount of fentanyl that we're doing, is we use the injection form of Narcan, it's naloxone, and we microdose it. It comes in little vials, and it's 0.4 milligrams. We turn one of those vials into either 4 or 2 injections, and we use the least amount that we can just to get a person breathing in. We don't care if they're sedated, because that'll deal with itself. We just want to get them breathing. And through using microdoses, people, they're not in what's called precipitated withdrawal when they wake up, which means that they're not pissed off at us, they're not yelling at us, they're not vomiting, which makes them a lot easier to engage with. And it just like, hey, you weren't breathing, I hope you're not feeling sick, can I get you some water, anything like that. And then if they're willing to, at that point you can talk about treatment options of like, hey, like if you're overdosing, like things probably aren't going super great. Is there anyone I can call for you? Is there anywhere that like you need to get to? Or is there anywhere you would like to go? And it builds trust with the community, because they know you're not going to come in and just like blast them with Narcan. I don't care if you're sick, I saved your life. And B, through doing that a few times, unfortunately, which sometimes we have to do for individuals, that you build trust with them. It's the same thing I do through wound care. I build trust with people. I show up, I don't tell them, you absolutely need to go to the hospital, you're going to die. I just treat their wound, educate them, And through building that trust, whether it's through overdose reversal, whether it's through wound care, whether it's through consistently showing up and giving them snacks and clothes and whatever they might need, when the day comes where that window of willingness opens, they know where to go. They know who they can call. They know where they can show up to see us and reach out for that help, which is really, really important because there's so many institutions or like avenues that claim to help, but if you don't do things exactly the way that you want or they need you to do, then there's a barrier, or there's 2 barriers, or there's 4 barriers, and that window shuts, and then people die. My friends die. So that trust is important, and that level of empathy for people's situations, whether they're a person who used drugs or a person who's just experiencing financial difficulties or just a person who wants to stop by our RV and say hi. Like, building that trust and being dependable and being honest and looking out for people is like the heart of what we do. I told you I get rambly.
Is this on? Well, first of all, thank you so much for what you do. It's just beyond words, making such an impact on society. I have a question you may or may not be able to answer. I've experienced all sorts of recovery centers and treatment houses with a loved one, and as you know, they're all over the charts. If one is successful and someone comes through successfully and is in recovery, are you aware of any programs that place them, keep them in society, show them what to do, where to go? That's what I keep seeing is the relapses due to there's nothing to do. There's nowhere to go. There's no job. Perhaps there's been incarceration involved. Are you aware of any institutions or foundations that work with such a thing, that follow-up treatment?
You aware of me?
Well, you, Savage Sisters, one. So, yeah, I totally agree. Support services. And so, the traditional method is to join an AA, an NA group, and find a sponsor to sort of be available and to answer questions and to help guide, right? And I don't reject that. I think that's fantastic. I know a lot of students at St. Joe's that come to our AA and NA meetings that are in recovery at a young age. They're in recovery, and they find that support and the folks around them being very supportive of them. But there is sort of this challenge. So somebody goes through, let's say, a 30-day, 60-day program, and then maybe they get discharged to a recovery house type of setting. But then what do you do after that, right? So there always has to be these connections. So people like Savage Sisters who have these recovery houses, like, they're aware that when the person sort of has gone through that, they still may need guidance. We all need guidance in our lives, right? But especially people with sort of that history of substance use. So I think that any recovery house and program that truly looks to the long-term recovery of people should also give that guidance. So in Delaware County you're talking about?
What county? Okay.
Yeah, so, go ahead.
So I have 2 points on that. The first one is we have a team member who that is their job. They're like a case manager. It's a fairly new role. It's my colleague Fran, to help people find a job, overcome any barriers like getting a social security card, getting birth certificate, because many people have lost that throughout the chaos. Basically, like, I don't want to say like figure out their path for them, but like figure out that path with them. And then additionally, there are a few organizations. Are you familiar with what like a certified recovery specialist is? So it's a certification that you, or a peer specialist. It's a certification that people can get through the Pennsylvania Certification Board. And it's basically essentially what you're asking about. They one-on-one with people, ask them their goals. If they don't have goals, help them find goals. Basically, I don't want to call it a recovery coach because that's its own thing, but it's basically like a one-on-one support for people. And there are a few organizations in both Delaware and Montgomery County that offer these services. To my knowledge, all of them are free to the individual. They're usually grant funded. If you're comfortable, I can give you my card at the end of this. I can link you either with Fran. I have a whole resource binder at our office of just like everywhere in Delaware County that offers anything like that, and I'd be happy to send you any resources I can.
Yeah, so I don't think we know of any institutions, like I think that was your question, like any like in-house, like, is that what your question was, like to go, okay. Yeah, but that's what I was gonna say to like Charlie's point is with a peer certified recovery specialist or certified peer specialist, it is an individual with lived experience. So it's not like a clinician or anything. It's somebody who has like been through it that can really relate to that person on like a one-on-one level, who's been through a training, got a certification. So they're not like pushing things on them. They're just like able to relate with them. Like, hey, like I get what you're going through. Like I've been there too. Like let's figure this out together. They usually do like what they call RAP plans. They're wellness recovery action plans. So I would also that would have been my answer as well. Recommend like a certified recovery specialist. Really good.
And also, I have on my phone for you after this, the name of the Shevlin Family Foundation. They were also given a grant by Delaware County government because they do work right here in Delaware County, and I really respect this group. They're great people to talk to. They don't have a house, they have knowledge, and so they know how to connect people. Does that make sense? Okay.
They're good.
Yeah, he just said they're good. Yeah, they're great. They noticed the same thing you noticed in a family member. It's a family foundation, so they had a family member that did great in treatment, did great, after treatment, and then boom, the bottom fell out because there was no support after.
We have a question over here, Steve.
I just happen to know of a business in Philadelphia that hires specifically people who've been incarcerated. So there are businesses out there,
Yes.
Triple Bottom Brewing Company, it's a microbrewery. So if they have an alcohol problem, that's probably not the best place for
Yeah.
them. But it is, they do specialize in hiring people out of incarceration, so.
You're exactly right. Delaware County has a business, I can't think of the name of it, that hires people out of incarceration, right? And then you're right, there are several food places in Philadelphia that hire people in recovery. They have Narcan on the countertop in one of them. It's wonderful. Yes, sir.
Hello again. Just a quick question regarding people who've had traumatic experience, PTSD, with or without, comorbidity of. I'm an older guy now, and I'm having a brain, having any mental health issues, and if they self-medicate, what are you finding is the most common agent they start out with?
It's really going to be individualized. Like substance use is such an individual thing. So that's what you would think, but like my personal experience, my first ever drug was an 80 milligram oxycodone pill, which is a very strong opioid pill. That was what I personally went for first. And I know people who have started with cocaine. I know people who have started with PCP, with weed, with alcohol, with nicotine.
I want to know why. Why did you take that?
It's not important. Yeah, sorry. I'm just trying. I'm not. It's really. It's just really individualized. So, like in my experience, it wasn't about the substance. It was about I don't want to think about, feel, or deal with in any way whatsoever this horrible childhood trauma that I experienced. And anything that, whether it was huff and duster or taking that first opioid or anything that would let me turn my brain off, I'm there for it. That's just my experience, but I will say, like, there's no one answer to that question.
Yeah, I liked promethazine with codeine personally. I'm a person who has struggled with suicidal ideations like most of my life, and it was because it made me sleepy. I just wanted to sleep and not think about things. So yeah, everybody's different. Yes, Steve.
So, Doctor, the lieutenant and I are experts on trauma. So, the research shows that the average citizen, and I'm not talking about, like, this room probably attracted people that experienced a trauma in their life, but the average citizen, it's about 2 or 3 traumatic episodes in a lifetime. So, research shows that a lieutenant and I and those in law enforcement, we experience about 188 in a 20-year career. So, Lieutenant, where's our favorite place to self-medicate after a hot call? The local bar, right?
The first thing I said was, and I'm totally uneducated, so I should have, I thought I got an answer, I would have said it's alcohol.
Oh, yeah. So, I mean,
Easy, it's legal,
it's legal, it's accessible,
accessible anywhere.
so till 2 o'clock in the morning at least.
It's
If you,
shift work, you can't sleep, so you have a drink.
oh, yeah,
You go to work and you go out with the guys, the boss, seem to have a couple beers.
yeah.
But I would never have guessed Charlie's story, and so.
Yeah, but if, you know, again, it's the first responder community, you know, we do have a lot of trauma, but unfortunately, there's citizens that have this personalized trauma that, you know, can start in the childhood, or it can be even later in life, but, you know, that self-medication is really, in my opinion, in lieu of professional treatment. So Lieutenant and I and our colleagues, you think it's easy to raise their hand and say, I'm sorry, Chief, but I need a few days off, I gotta see a counselor? Oh my gosh, no. It should be, but it's not, yeah.
The way it's explained to me, and I will, like, these people are advocates for things they do. I'm not an advocate for anything, but I will tell anybody, listen to, I see a therapist, I go to a therapist every month.
Wow.
It
Thank
doesn't
you.
get paid for fully by my insurance, so some of it's out of pocket. And the best thing I got was, when it comes to trauma, if you think of a box in your brain will take those traumatic events and stuff them in that box. Eventually, that box gets full. No matter how small the trauma is that comes, if they try to stuff that in there, something comes out. You have to eventually be able to deal with these traumas.
Thanks, LT, for sharing that, that's really courageous.
Where we get to 190 traumas in a lifetime, I guarantee you, traumas aren't as big as some of these people in this room experience,
Yeah.
you've experienced, the people that they deal with every day, and that fills up that box a lot faster than my 190 traumas.
So, yeah, my counselor friends treat Philadelphia police officers, and you could have a Philadelphia highway patrol officer with the leather, you know, they got the leather boots, the leather jackets, I mean, they look tough. And their spouses sometimes will throw their clothing out in the front lawn because they're so sick of coming home drunk, not taking care of the kids. And so they have to go to treatment, right? and they go to treatment. And my friends counsel Philadelphia police officers in particular. And the first day, it's, oh, I was in a shooting. Saw this car crash, burning car, all the trauma they saw. By the second day, the tears are flowing from what happened in childhood. Like, you're exactly right.
100%.
Exactly right. And you know, and they're courageous enough to go and they get help. And by the way, treatment works. I mean, there are folks that have lost everything in my field, and you know this, like, there's people that have really sunk to levels where you think they'll never recover. We meet people in Kensington, I meet people in Kensington that are using 20, 30 bags of heroin a day, or, you know, dope a day, and these people get well. Like treatment, support, when they're ready, right? You don't push people, but when they're ready and they say, yes, I need help, and it might be a few treatment centers, average 10, 12, honestly, it takes time. But the bottom line is people do get well. And so I always advocate professional treatment. You get varying degrees of it, but what I've learned is that you learn something every time. Even if the treatment center isn't helping that at the moment, you know, I don't know, call it like a not good treatment center, people still walk away with something that they think about and reflect on. So, yeah.
I So I work in healthcare, and I have to say, it infuriates me the way our country looks at mental health. And, you know, even now, we're seeing physical health, the insurance coverage for, you know, a lot of people. If it's there, it's minimal. You know, it's disappearing quickly. What can we do? Is there anything that you could suggest that we could do to maybe help change this?
So just if I just want to jump on top of that, because you're 1,000% right, but if you add to the fact of codependency, mental health, and an addiction disorder, that mental health that was available to say to one single diagnosis gets even smaller to those that have
Exactly.
multiple
And this is a population, I mean, I'm going to be honest, I lost a child to this. And it was back in 2013. And I never kept my mouth shut because I really believe that in order for us to deal with this, we've got to bring it out into the light. We've got to talk about it. You know, turning our backs on an entire population is not an answer. A lot of people looked at me and they were just, you know, I had people say, I actually had one person say, well, it was her choice. It wasn't like she had cancer. And I thought, oh, it was close. But I had other people, I found it opened up a door for most people who said, oh my God, you know, it gave them permission to talk about it. And a lot of her friends who were still active in their abuse said at her service they had never been to a funeral where people talked as openly about what we can do to help. So I guess for me, I look at our society and things change when we speak about it, when we do something about it. You guys are doing amazing work. What can everybody else do? What can we share with the rest of the population?
Great question.
This is a wonderful question.
Yeah. Can I jump in? Thank you. Just, so I worked for a district attorney, Monco, 5 district attorneys in my decades career. Then I worked for the Attorney General. Happened to be Shapiro, Josh Shapiro, when he was AG. Look at her. But I've seen Shapiro, I've seen the Attorney General sit in the boardrooms of insurance companies and say, you're not doing enough, right? You know, 5 days for a 5-year heroin addiction, 5 days to cover treatment is ridiculous. And he was, first of all, he walked in, he says, I don't think you're going to want to hear what I have to say. And then they were like, oh, no, we'll listen. And then boom, he blasted them, right? And so here's my new insurance card. And on the back, it says substance abuse and mental health phone number, right? It didn't used to be that way, okay? Like, we didn't always have that guide, that key in the back of a card. So here's what I suggest for you to do. I want you to share your story. I want you to write the current Attorney General of Pennsylvania, Dave Sunday. I want you to write Governor Shapiro and remind him. There you go. So I used to bring him to homes where moms and dads lost their children to addiction. And one time I whispered in his ear and said, her son died right up the steps here. Like, that impacted him. Impact the influencers. Now, Savage Sisters, they do great. They advocate right there in Harrisburg. They're always around. They're always speaking up. But we want influence to hear from you and others as well, right? Everybody should feel very comfortable, even handwriting, an old-fashioned way of writing a letter to the Attorney General Dave Sunday. Hey, just a reminder, make sure insurance companies are doing their job. Here's my story. Please share that. Your loved one would appreciate that, right? I mean, you know, and there's a whole lot people, everyday people like I am now, I'm retired from law enforcement, can do to advocate. And please do it. And then help out organizations that are doing good. If you volunteer, go see this guy in action down in Philly doing wound care. Like, it's unreal what happens. But as long as you have breath, keep using your voice, write, email, bug the crap out of these people. And we're recording, so I can't say anything else.
My answer is less optimistic. I've tried to seek mental health help while using drugs to varying levels of disappointment. And I'm sure, I mean, I've been abstinent for a good few years now, and maybe things have gotten better, but like, I don't think so. Our our system, when it comes to behavioral health and mental health, it works the way that it works by design. That's by design. It is expensive to give people the continual treatment that they need for successful mental health healing. Our current system is designed to burn out our helpers. It is designed to frustrate people so that they stop signing up for counseling. Right now, if you want to go see a therapist and you're on Medicaid, if you don't have insurance through work and you don't have the means to purchase your own insurance, you're on a 3-month waiting list for one appointment. Your next appointment after that's going to be 3 to 6 months after that. I don't want to say it's like a funding issue. I'm sure more funds like would help, but I have private insurance now. If I wanted to go see a therapist, I've still got a multiple month waiting list to even get an initial intake.
And the coverages are
Minimal.
abysmal.
Yeah.
You know, nobody has that kind of money to put out for any kind of long-term care.
And that's what is proven to be effective is long-term continual. It's like maintenance on your car, but it's maintenance on your brain. And there's unfortunately very few, if any, options for that. I do agree with Steve. Be pissed off. Be mad. Tell everyone you are mad and why you're mad. And the more mad people we have, the more likely things are to change. But I'd be lying to you if I said it wasn't an uphill battle. And I say that as a person who is an advocate for like drug user liberation. That's an uphill battle, and what I'm telling you is your battle for, in my opinion, what needs to be done, rewriting our mental health system. That's a steep hill.
Yeah, and I just want to add, I have a pretty extensive background in mental health advocacy, and then I got burnt out from it. A lot of legislative advocacy I'd done for years. I also have a background in a lot of suicide prevention, a lot of suicide bereavement and loss. And every time I'm in these rooms, people are like, oh, we got to normalize mental health. I'm like, no, before we want to talk about normalizing it, let's advocate to make mental health actually accessible, affordable, and accommodating before we have those conversations. So I definitely agree with Charlie. You have to be mad about it, loud about it, because people, I think they don't understand. They look at people and like, oh, they can just go get help. I'm like, you have any idea how hard it is to go, or actually or find the right treatment or provider or therapist, whatever your choice is that actually works for you? Because not every therapist is going to be a right fit. And then you just get so defeated and you're exhausted and you don't want to try again.
That was my daughter's issue. She just hit a point where
Yeah.
it was easier to use the heroin.
Yeah.
Then she just didn't care.
Yeah.
Like,
Yeah, I mean, just self-disclosure, I lost my fiance to suicide when I was 24 years old, and I found him. I was in a very dark place, and I was drinking so heavily because I was grieving, obviously. And my therapist and psychiatrist at the time, they stopped all my treatment. They're like, you need to go to Alcoholics Anonymous 3 days a week. We're taking you off cold turkey or medications. We're not seeing you. My therapist left me the darkest moment of my life that I was already with prior to this happening. Finally, I met the right psychiatrist, and he was just like, you're not an alcoholic, you're grieving, and you're really lost. He was like, no, you don't need this. He was just like, I'm going to make sure you get through this. So it's like just having somebody just listen to you and actually hearing what you're going through, it just can make all the difference.
So advocacy is a very important issue, and there's various things to advocate for. One is this. So there are not enough professionals in the treatment industry. There really aren't. And also burnout. That is imagine being a drug and alcohol counselor at whatever level. Maybe you have no degree, you have an undergrad or a master's degree in clinical mental health counseling. It is hard work, right? It is hard work. So someone, again, advocated to St. Joe's University, where I worked last 5 years, and said, you have got to really get serious about substance use disorder. So we started a recovery house on campus. I mean, no one ever thought of that before. We have a robust collegiate recovery program, and then we added the graduate level clinical mental health counseling degree with a minor in addictions, which is really pushing our graduates to fill these empty seats in treatment facilities and recovery centers, at that level of having a master's degree. And so being able to hang a shingle and be able to treat people and also get appropriately, like, honestly, you get a graduate level degree and the clinical hours, you can charge insurance companies. So at least you can pay your bills, right? So advocacy could be telling your local school or if you're an alumni from a college that has never thought about filling those empty seats in treatment centers by offering some type of education. Like, that's a different way to look at a problem. And our school does it, which means they market it. That means people get interested in that program. And all of a sudden, and we find so many people in recovery taking it. It's like beautiful. Like, they have lived experience, and now they're getting a degree to get them to help. It's a win-win for everybody, including the university, right? So please advocate. Yeah.
I do want to be mindful of time. We only have about 3 minutes left, or 2 minutes. Does anybody have any last-minute questions, comments, feedback? We're also open to doing these listening sessions again, so feel free to connect with us. We've been all over Delaware County trying to promote other listening sessions. So if you have any information on where we should be headed, let me know. Yeah.
So we do have we've offered our trainings in quite a few schools, primarily in Philadelphia, primarily high schools. I've gone and done talks at some elementary schools as well. Obviously, a lot different from like what we would give to the high school or like a business that wanted the trainings. We are having a little bit of difficulty getting into Delaware County schools. I actually just got a text about this because we have to go through the text is in your phone. There's some board that we have to go through, and we were given a contact on that board and have not gotten a...
There's nobody here from Radnor School Board.
They're not here tonight. They were on my target list.
I will tell you, this is me speaking, this is not Lieutenant Pinto speaking. You're not going to get them in our schools because there's no problem in Radnor. Your kids don't have problems.
All right, so let me add something.
We don't come to this township for the school.
Yeah.
So they bring these people, and I say that in all due respect, I'm not trying to. And they admit that there's a problem,
Yeah.
then you can't flip them.
And I would just like to point out that our two co-founders are Radnor High School graduates.
So I'm just,
Yeah.
I'm not saying it's the same.
All right.
Well, I'm going to give you a really positive update. So St. Joe's University has totally bought into advocating and doing programming for substance use disorder. We started a prevention academy within our School of Education. Delaware County gave us a huge grant for all Delaware County schools, and it is in its infancy, and they've already educated thousands of Delaware County middle school and high schoolers. You haven't heard much about it, but if you check out Prevention Academy at St. Joe's, I think their website's pretty active. We are going to get every school, Lieutenant. We're coming, I'm telling you. We're coming. But it's not the old-fashioned prevention, that I know I got. Like if you smoke a joint, you could die. And I'm looking at my friends that are smoking joints, I'm thinking, they're not only dying, they look very happy. Yeah. So it is true prevention. It is researched projects that they do. And the people that lead it have led it all over the world. Like, we have world-class people leading this. They don't judge people. You guys will love what they do. And because Savage Sisters at St. Joe's, you know, we're really connected. Like, we love Savage Sisters. They were there today training our students on Narcan. And so I will make every effort to include you in our Prevention Academy work. And every one of our prevention specialists are people in recovery, and they are taught and trained how to engage and not point fingers and judge. It is a beautiful program. So wait and see. Right?
And that being said, if anyone knows Maria with the Delaware County Intermediate Unit, please tell her to answer our emails.
Are they still doing like the DARE program around here?
They don't do anything.
Nah.
Let me rephrase, I'm sorry.
Okay.
They will bring me in, and they will invite me to talk about, the law and what they can get in trouble for.
Oh,
They will let me talk to teachers about trends that I see, but never the students. The students get what kind of trouble they can get in and what they're looking at, and do they have to answer the door when I knock on the door, do they have to do this, they have to do that. I was born and raised in Upper Darby, I'm the son of a police officer. I thought I was pretty worldly, and I said, with all due respect to people born and raised here, I've never met people like, again, this is me, in this town, they are a different breed of people.
Just be careful, we're being recorded. Yeah. So LT, I'm going to invite you, I want you to meet our Prevention Academy folks, because I want to have you briefed on what we're doing.
The teachers would love it. The
Yeah,
teachers want it.
they're the ones that are really,
They're in the classroom every day.
Yes.
They want it.
do you want
Yeah.
us like to name it something else, a little sneak in there? Because we can do that.
yeah.
I will say something we had a lot of success with as well is I was blessed with the opportunity to train the entire school district of Philadelphia's nursing staff, which I think is also very effective should there be an emergency at the school or at any of the schools. And that was that got us invited into a lot of classrooms as well.
So can you answer, does the high school, the middle school, do they have Narcan on campus?
Yes.
Oh, good.
Have they been educated on the uses of, and the new trends, for lack of a better way of putting it?
They've been given, because I don't want to say I did for all of them, they've been given basically the speech that I gave about Narcan.
Okay.
When in doubt, give it, because it's not going to hurt anybody, and it's going to save lives. We hadn't got into the xylazine, all that other stuff yet, 'cause
But they should even be educated on, you know, fentanyl-pressed pills and fentanyl contamination
Well, that's
in
the thing, we tell
cocaine
these
and
kids that
fentanyl
it's
test
in
strips.
everything. And you think you're
Yeah.
going out and you think you're getting 30 milligram oxy, or you think you're even getting some cocaine. The next thing you know, your buddy who does lines with you every weekend does a line and he drops down, turns
Yeah.
around, he's not breathing. Like, that's not cocaine. You got fentanyl in your cocaine. He's going to die. You need to do something. They're real big. They want to teach the Good Samaritan laws, which we teach ad nauseum. And I am proud to say we followed that law long before the law ever existed here in the township. I'm being too hard on my shoulder, but there's just resistance. The schools in this township are their gold. They're Mount Vesuvius. They're everything in this township. And they protect them, I would argue, to the point of the detriment of the students.
So could the township put something on their website? I know I have some history and experience in this, and people have come to me who are experiencing that type of thing, looking for resources, to which I try to send them out to different resources and things. So if you can't, you know, and then it's scorched earth because it has happened to them, and so they need to do something immediately. Could the township, if they can't get into the schools or into, provide something so at least the parents, when they do have to face the music, have a path that they can, like, this is fabulous. I'm gonna tell people, you know, look up Savage Sisters, absolutely. There is a path there that will help you, your child, your loved one, whatever. something where the schools are not, but at least,
So my gut instinct would be, I believe the township would probably gladly do that. However, I am in no position to make that decision or answer. The person who runs the township is Molly Gallagher. She's a wonderful woman. She's who you would reach out to.
is that like a Board of Health thing, or would that
She-
be a community?
She'll probably refer you to the Board of Health, but Molly Gallagher is our Director of Public Relations. She
Yeah.
runs all that stuff. She's kind of like a board of one person. She only answers to the township. I can't, in my head, off the top of my head, think of any reason why they wouldn't do that, but I would never be in a position to tell you
Right.
that that'll happen.
Fantastic questions.
Thank you so much for having us, everybody.